Well, you'll see. I guess we're recording. There'll probably be, I don't know, 34 people in the room. And that camera is actually projecting for people online who may log in, and that's actually what's recording the session as well.
Sounds good. There as well.
So you're totally fine. You don't really have to look at it, but you might want to stay in this space. If you walk over there, you'll be off camera. I can steer the camera as needed.
No, no worries. It's all good. And I guess it's informal enough. You can prompt me if you say, hey, Rheena, if you could actually do this.
This is kind of what people see by default.
All right.
Sometimes I can zoom out or somewhere, but by default, it'll be about here.
Awesome.
Grab some food, grab some drink.
You understand?
We should chat after this. There's an event that we're planning. Other than planning.
The orders are talking about.
If there's other requests, let me know.
But
I had a meeting.
but I thought we could focus on you and I.
And at the same time, I don't want.
Basically.
Let me know if it's not. We can discuss it more.
Oh, yeah. And it's based on one of his something that
I'm so close.
no, it's not in, maybe in New England or something like that.
Did you just say should have helped?
Yes. Yes. And the,
Was the
like the
perspective
pre-visit, visit, post-visit, opportunity thereof, I think. So, I've spoken to him and I've spoken to.
Call me down.
There's somebody who worked with, oh, Stacy would, do you know?
I think nature would
I worked with Stacy on this, for this.
They might not have.
And so she might just, I don't think she's, she
I'm all for it, but
And
we should
so
definitely consider this one.
she might, join us virtually. Kevin's gonna, it's gotta be an in-person. Do you think she's?
I think this will have more visibility for sure. Not like what you see on the website.
Yeah, so May 14th.
Not just
May
visibility
14th,
of
we'll give
HCR.
you more. So we're working with Veronica too.
Let me know. My
yeah,
schedule
we
gets
definitely-
jammed real fast,
I
but
can imagine.
tell me whatever it is. We'll try to figure some out.
Yeah, see if that, I think it'd be a great discussion point and you bring in entrepreneurs and investors and people from academia and all that, private, public, everything.
All exciting. Right.
I know, makes everybody else guilty, especially when the menu is
Tomato with a salad or something. I'll have one slice. I'll just have one slice. I can have one slice, like why?
You have to whisper in Lionel's ear what he needs to order next.
No. It wasn't even salad at all. I just had to eat the chicken masala. And I tried naan instead of rice. I should have had the rice. Or I should have not had, I don't know. You bike a lot, don't you?
That is true, no.
I'm trying to do that more, but I don't have a habit yet.
I try to exercise at least 30 minutes per day.
That's worth a lot. I definitely do not do that. I may sometimes exercise 30 minutes per week.
Has to be long. I was thinking of something.
I didn't yet. Let's start a log in. Let's do maybe just another 30 seconds to 1 minute. We'll start, we'll get started. People just log in, settle down. See if the line- Go ahead and get started, at least informally, just to make good use of our time. We're very privileged to have Dr. Rheena Bhargava with us, who I ran into. I was giving an inaugural talk at the Kaiser Institute for Medical Educators, and we had some fun. She approached me, started telling me about she's doing this and that, and they're like, wait, stop talking. Let's just get you in here, because actually everybody needs to hear what you're talking about. Before we dive into the depths of it though, Dr. Bhargava, please tell us about yourself. Who are you? Where did you grow up? Where were you born? And how did you end up arriving at what you're doing? And why you do what you do now?
Oh my gosh. Now that might well take a full hour or more. So somebody's got to keep time. But so nice to be here. And right now, for me, it was like a 5-minute drive. But when I did come, I grew up in India. And I came to this country, because my husband wanted to be in Silicon Valley, right? So, computer science, PhD, where else do you want to go? And so I must say, I was a reluctant, partner on that aspect. Like, in my country, why am I going there? But the first thing I did when I came here was a fellowship in the endocrinology department in here. And I worked with the chief of endocrine, Jerry, and he was chief for many, many years. Those folks who may not have heard of him, he was absolutely the international guru. Insulin resistance, metabolic syndrome, all of those things. And I did my NIH fellowship here as well. We did all those insulin clamp studies, called patients in at 5 in the morning, ran that to really understand the metabolic parameters and things like that. Always an amazing experience. I resigned from this fellowship to start at Kaiser, and Jerry told me, you don't know what you're doing. Nobody ever resigns from an NIH fellowship. But I just wanted to go down that clinical path. And very soon, I've been a medical director at Kaiser for 20 years. And I pivoted to kind of looking at care delivery systems, clinical decision support tools, building them for the telemedicine platform, building them for the digital platform, population health projects. I mean, I love data. And when you dive into that and you've got the richness of an organization like Kaiser, and for folks who may not know that, Northern California Kaiser is different from Southern California, though we're all joined in a certain fashion, but you've got an integrated system. So guess what? You know the outcomes for patients, and you could drive that. You can make a real difference whether you're doing population health or specific. So I got board certified in internal medicine early on, of course. And then they came along with a specialty called clinical informatics. So I got board certified in that a few years back. And then they came up with another one called lifestyle medicine, which so tied in with the stuff that I'd done with Jerry, all related to metabolic syndrome, pre-diabetes, diabetes, and so forth. So I thought, let me do that as well. So that's kind of where I am, and I left Kaiser in August. The work we were doing touched millions of lives each year. It was amazing impact. And I just thought, hey, with AI being where it is and stuff like that, let's just pivot and do something else, drive things for what they might be in the real world outside Kaiser and so forth. So that's where I also, they gave me this clinical professor for the Institute of Medical Educators. And that's where I was there to receive that recognition as a clinical professor. And that's when you were there, Jonathan. I'd actually left Kaiser about that time, like a few weeks earlier. But they invited me for this. The process took a while, as things go, looking at all my publications and this, that, the other. And so that was a nice recognition, nice nomination to be a clinical professor. All through the years at Kaiser, I ran the journal club for the residents every month for the medicine residents at Santa Clara. And we had a number of Stanford students rotated through as well. That's my relationship and, growth process, you might say, with here.
Fantastic. Well, glad you're here. If you'd like to dive in, we'd love to hear more about the specifics of many of the things you've been involved in and what you're looking to do next.
Thanks. Well, folks, this is gonna be fairly informal. We've got a room full of, I think, amazing academicians and scientists and researchers here. Stop me whenever you want. And I will walk us through this stuff that we worked on, which is called electronic visits. A really efficient tool for patient care. So there are many, many projects we worked on, but for today, let's kind of dive into this. I published about this as well in JAMA, Network Open. And so, sharing with the outside world that there's so much that we can do, creating another platform for patients to access us. So none of this is new to us, right? I mean, we've heard about physician shortage and access to care. Just on Monday, I was having lunch with two of my colleagues, my previous Kaiser colleagues. One of them is now a cardiologist here at Stanford. And she shared that initial consult appointment is out as far as May. Her return appointments are as far out as November. Like how do we take care of patients if that's the lag time for them to see their cardiologist? But that is the truth of the matter. And this was pre-COVID as well. Pre-COVID as well, we didn't shine the light as much. But within the Kaiser system, where we continue to modulate things, and that's 4.5 million patients in Northern California, a few thousand primary care physicians, you can really know exactly how many patients called and how many got the appointment, how many didn't. What was the unmet demand? And knowing that, one can leverage so many aspects to this. Who absolutely needs to go to the emergency room today? Despite they saying, no, really my niece is coming, on Wednesday, and that's when she kind of bring me in. Well, Mrs. Smith, you really need to come for what you're presenting. Versus, there's always a want. I want to be seen today. I've had this back pain for 10 years, but guess what? Today, I just want to be seen. And so there are different ways clinically. And again, the patient is looking at the customer, so all of their needs and wants that are real, but we need to accommodate. And we never ever had enough appointments. That's the truth of the matter. But COVID, as we know, really changed the game for us. And so thinking about this is what we launched in 2018, July. These are asynchronous digital tools for physicians to provide patient care. And the key feature would be that the patient fills out a structured questionnaire about their symptoms. These questionnaires are built by clinicians, built by us. I led the medicine out of all of this clinical decision support tools on the telephone platform, on the digital platform, working with the chairs of the chiefs of medicine, the chiefs of infectious diseases, ED. So really, it's consensus building. And as you can imagine, that's not easy, but there's nowhere we can be successful if we do not invest in, hearing them, building something that works for most all of them. Clearly, all of this had to have strict inclusion criteria and strict exclusion criteria. You're feeling a little short of breath, you really can't do asynchronous digital care, right? And so how do you siphon those folks off effectively? So it's a great patient care experience. That's paramount. Clinically safe, paramount as well, right? So, multiple priorities, and you kind of build around that. The expectation set up front, a clinician's going to review that. It's a physician, actually, the way we've set it up. And they'll respond within a set time frame. So you set expectations. It doesn't meet the expectation. It's going to be 7 a.m. to 7 p.m. It doesn't meet the expectation. It's a simple problem. And some of those patients may well go up in the emergency room at 6 a.m., even though it's a really, really simple problem, but they just couldn't wait till 7 a.m. That's the reality. That's what's happening in our medical structure. They can upload images. This is how we built this system. They could upload images. We can share lab results with them. We can share other stuff. So what that was really omni-channel care. Let's meet a patient where they want to be met. The person who has a concern at 9 p.m. really doesn't want it. We've got a 24/7 functioning appointment and advice call center with 1,000 advice nurses for Northern California, 1,000 clerical staff, but they just don't want to talk to someone. Right? Enough folks like that, right? They'd much rather just click. Well, and we meet them there. And that was the unmet need that we did meet with building these electronic visits. Improved access to care. We know we would not be able to, not everybody wants. No, thank you. I really, really want to talk to my physician. I really want to come in. And so if we can take off, even, in the whole broad scheme of things, if we could take off 2% of the need, about 10% of the need, maybe more or less, in a system that is overloaded and where physicians are overwhelmed and what have you, those numbers are huge. And so that's where it is, providing some flexibility for patients, physicians as well, and work from home to take care of this. So that's remote care. And some of that then reduces the burden on in-person visits. So with physician shortage now, more so, this would really, really make a difference. The foundation for this, of course, is got to be part of the electronic medical records. It cannot sit alone. That's an easy platform to build. But the moment you do that, ain't gonna work, because you might well miss the fact that this patient had a cardiac procedure last week or whatever else that might be, something that we really, really want to pick up on. You're saying you're not short of breath, but something else out there that you were seen for something, and now you're just having fatigue or nausea. So, and I'm gonna be, putting you in a higher risk situation because I know your medical history. So we need that. And then this functionality at Stanford, at Sutter, we're using Epic. You guys may well know that. And that's exactly what we've been using at Kaiser. So a functionality in Epic that integrates into the patient portals. Now, what were those? For Northern California, Kaiser, we have 2 patient portals. One's kp.org, everybody goes there. And that's for all the whole nation, whether it's Kaiser Southern California, Kaiser Hawaii, et cetera, et cetera. So it's this big mammoth platform. And you have to build consensus with everybody to do that. While Northern California, we built another one called My Doctor. So for most Kaiser patients, they've actually got 2 patient portals they can go through. And that's where we have a bit more autonomy. You can make quicker changes and so forth. But bottom line, make it available and integrate it with your electronic medical records. That's the idea being we do that, and patient doesn't maybe need to pick up the phone or email their patient or hook themselves up. And interfaces have to be really, the best we can do. So obviously you're sitting on the desktop, you've got a big wide screen, and you could have multiple questions out there. When I'm on my phone, it's a really small screen. Don't make me, peer at it a lot. And so we were restricted with the user experience. Just maybe include 7 bullets, 7 questions per your screen, so that it's easy for the patient to go through that. All of those considerations, as you put them together to say, how do we make it a great patient user experience? The high-risk situations, if they're really infrequent, do you need to put them up front on screen 1? Or would you rather put it down screen 3 just because it's infrequent? But on the other hand, I want this patient to answer about 10 questions and then be bumped out, right? So it's this balancing act. And what we did was, we had this core group of physicians that built these clinical decision support tools. Subject matter experts, practicing physicians, chiefs, and what have you. So I've been leading that group for 20 years. And the expertise we've built over that time, not only for being practicing physicians and knowing what we need, or knowing what our peers need, we're representing a few thousand physicians, practice style and so forth, but also data-driven. So we've known, like for the 14 million calls that are coming in, for X number of patients that are coming in, what percentage of the knee pain is going to the emergency room? What percentage of that, when we added 2 extra filters, 2 additional questions, clinically speaking, or just workflow-wise, did we now move over to a messaging system so it's not eating up our appointments and providing great care? Because there's only so much, and again, back to that balancing act. So it's evidence-based care. Want to practice really good medicine, but at the end of the day, it's also community-based care. Because there's so much in medicine that we frankly do not have evidence about. We practice because the next person practices like that, and I was taught in residency to do that, where we go hunting the literature in there. And yet we're safe because we practice in that fashion. And so bringing in that community-based knowledge, that wealth of knowledge, together with what is there in evidence, this is safe and there's a great randomized controlled trial to prove that, let's pivot. The guidelines have changed, so all of that went to do this. Adoption and change management. I actually added that bullet just recently, and that's because on Monday when I was with my colleagues, and one of them was the chair of chiefs of medicine, who was chair of chiefs at that time when I was building this, and I told her I'll be talking about the e-visits on Thursday. She says, Rheena, don't forget to share with them how much resistance you got from so many quarters about this. And I'm like, oh, thanks for reminding me, Cheryl. Yes, I forgot about that. Sweet success, e-visits worked. But the amount of pushback we got, if any project that you take, it's gonna take huge amount of dollars. It also takes away resources. So there's that. But also huge concerns about, is this gonna be clinically safe? Which is kind of, one of the biggest pieces we have to work with in clinical medicine. The last thing you want is, somebody thinking they just have, my chest feels tight, maybe I have a cough and a cold, and that's really not the cough and the cold, that is your cardiac ischemia. And a terrible outcome for the patient. terrible for the organization, meant legally, what have you. There are all of these balancing things that we have to do. So that obviously was a huge reluctance in providing care asynchronously. Somebody just puts in a questionnaire. What if they had a good understanding of the question? What if they provided us reliable answers? And we are now planning all of that care with these, short list of questions. And so it was a discussion or review and so forth. There's no doubt about it that we would monitor it up obsessively. And so amazing reporting department that gives us data, helps me with data, slices and dices it exactly as we wanted. Because as we know, there's data and there's reporting departments and so forth. But what goes into the numerator, the denominator, the variables that were included, that is so essential. And so kind of looking at that to say, these are the pieces these are the outcomes we absolutely want to know about. And in this, do not include this because, this variable really doesn't, it change the result here. I mean, it's noise rather than this. So understanding the clinical aspects, understanding the data aspects, the outcomes, all of those were required to do this. And we, yes, for the first so many months were, any complaint from member, we were just like, did we get any member service complaint? Did anybody from the emergency room come up with an issue? Which of these patients showed up in the emergency room? Oh my gosh, why did this person with simple urinary tract infection putting in an e-visit show up at the emergency room? Well, it turns out that she could not wait till 7 a.m. Showed up at 6 a.m. just because she wanted to. I mean, so it wasn't clinically unsafe, but all of those things need to be monitored as we're building a whole new system in a whole new way. Patient interfaces, as I was mentioning, concise questionnaires that really lend themselves. And so it's kind of, it's not the huge review of systems that we do when a patient walks in. We know we don't have the vitals on this patient. We're not seeing this patient, they're clammy, sweaty, what have you, and they say they're feeling great. Well, that's what are the clinical red flags we can add just so that the patient stays safe and we're practicing safe medicine. And so meeting the operational needs, kind of building that up. Who's going to take care of these e-visits? The primary care physician says, I am so overwhelmed, don't give me another channel to work with. I'm already drowning in these emails and telephone appointment visits, video visits. So I was reviewing that and we made a big push for telephone appointment visits somewhere in 2008. And then 2016, we made a big push for video visits, which basically means all these clinical decision support tools that we built, now we got to evaluate what lends itself to also offering the patient a telephone appointment visit and also offering a video visit. So all of that coming to the physician as they switch gears, right? Like this one's an office visit, this one's a telephone visit, this one's a video visit. Now you want to add an electronic visit, how folder for them to go to. And so again, with sorting things out, making a decision, let's give this to a pool of physicians that have dedicated time to just do this and they're not distracted by anything else. The ability to upload digital images, that was a really nice feature we added to our electronic visit. So for example, you got a pink eye and you wake up and like, oh my gosh, I don't know what this is. Well, you don't need to wait to go in. You don't need to set up an appointment. 5 a.m. you can send you an electronic visit and upload your picture with a smartphone and things like that. Also, we put in some classic photos to identify this is subconjunctival hemorrhage. So it's a tiny little break in the of a blood vessel in the eye, and suddenly you're like, oh my gosh, my eye looks all red and stuff like that, and it's not itching, it's not burning, it's not pain. What's going on? That's a very simple thing, can happen, but that digital picture is what's gonna Otherwise, I'm also guessing if I'm just talking to you and things like that. So all of this really made it a robust platform. For the physician, how did we do this? We built all the clinical decision support tools. Add smart phrases, order sets, add the prescriptions, add the lab tests and diagnoses, so their processing time is really good. Build smart phrases for each symptom. For those frequent clinical situations, kind of really think through that process. What would the workflow be for the physician? Just so it, now, what are they going to do most of the time? Because you're expecting a huge volume. And now remember, this is before we had AI and so forth. And this whole AI and machine learning and stuff like that can really change the game here. But we set this up prior to that. The expectation really for the physician was review this within 2 hours. And guess what? This then took 2 to 3 minutes of the physician time instead of the 20-minute visit schedule to 20 minutes of office time or a video visit or whatever that is. Communication is through, of course, a secure message portal. Everything is in their electronic medical records. So by the way, they do show up in the emergency room or either PCP, get another message from them. It's all there, it's visible. But otherwise, I don't know about it. It's not noise for me, the primary care physician, because somebody else is taking care of it. It's in another channel. And again, I've been offloaded. So the objectives are, we set up a research study once we got this going operationally. We looked at the outcomes for sure, and everybody around was sure that this was safe, this was efficient, it really worked. What's the adoption rate? What are the demographics? I mean, most people get a sense. The older patient's not gonna do that. The older lady's not gonna do that. Well, we can build that theory. What is the utilization? What's the success rate? How do you define that? What's the effectiveness in providing timely care? And so, operationally, I'll share that. Working with our leaders and so forth, they really wanted to look at a 72-hour time frame as this is successful. If the patient doesn't access care within 72 hours following the e-visit, you did what they needed to do, patients taken care of and so forth. Somewhere earlier, I had worked with our reporting department, which they are my favorite people, and they're so kind and listen to me. Said, let's go out 7 days because some disease processes, whether even it be a sore throat, a couple days you feel better, then you think, not that good, I'm feeling a bit bad. And 5th day out, you're like, what the heck? This hasn't gotten better. And so in that sense, that e-visit that was done was not successful, right? In that whole the whole disease process wasn't well managed, however it would. So operationally, we were working with a 72-hour time frame. But when we came to JAMA to publish, the editors insisted we do a 7-day time frame for outcomes and so on. Thankfully, we had that 7-day data and we could pull on that, but it just gave us another kind of a time frame that not only for operational reasons, but for academic reasons, et cetera, we said, we're gonna stick to this now for everything going forward. And so in this time period, just kind of reminding you, COVID hadn't happened. That's the data I'm pulling. And we've got lots of data beyond that, of course, it went nuts. But this was pre-pandemic, 21,000 visits. These are the kind of symptoms we looked at. And then this is how the adoption happened. And this is with no marketing, no this thing. I have to fess up. I worked so darn hard on this stuff. It was leading the development, the clinical development of this and so forth. And then a few months in, maybe it was October, November, I was asked to present and talk about that. And then somebody turned to me, so how do your patients take it, Rheena, when you tell them to do e-visits? And I'm like, shucks, I don't tell them to do e-visits, I forget about that. Like, when I'm seeing my patient and they've got back pain, and they've got this, and they've got, whatever else, heartburn, and their cholesterol's high and their blood pressure's high, like, no. So there was no marketing, no promotion. This was self-discovery by patients when they went to their portals, whether it be kp.org, or the My Doctor Online, etc. It grew. And if you look at that bluish green, whatever color that would be, the bottom part of the bar, kind of explains it, upper respiratory infection. So there's a seasonality for sure, and what comes into us. This is when we get overwhelmed every year, pre-pandemic and before. And so multiple strategies we've built with extra telephone appointment visits and so forth. You really don't want these patients with tons of virus around them to come into the clinic and so forth. That's how we practiced. Old-fashioned medicine was really that. You're sick, you want to be seen, I got a little cough, I got a scratchy throat, and so forth, come on in. But there are much better ways to take care of our patients, and our patients ask for it. So follow-up care within 7 days after their visit, whether it be a secure message that the patient sent. We counted for that, like didn't do enough. If the patient needed to send an email to their primary care physician saying, my cough hasn't gone away. Well, let's maybe we could have done better upfront in that electronic visit, in the smart phrase that we had built for that pool physician to send off. Is there something else we could have done? Of course, emergency department. Oh my gosh, what did we miss? Why did this patient go?
So were all of the patients included in this program, were they already connected with care, or were there any initial users as well?
We connected with care, meaning did all of them have a primary care physician, etc.? I didn't check for that. The empanelment rate, just because Kaiser, Northern California particularly, is so much into preventive care and what have you, especially pre-pandemic, the empanelment rates were close to 98%. So, but excellent point. Didn't specifically look for that, though most likely, most all of them had a primary care. So what did we find? That 81% of these patients did not seek follow-up care in 7 days. And we looked at that. The predominant users were under 40, were mostly female, but there was usage across all age groups. And most common, upper respiratory infection, and that kind of explained how it went up in the winter months, just kind of without any effort on our part, just organically, and then some of these concerns. And this is what our follow-up rate was. Within 7 days for all of those. A small percentage went to the emergency department, we checked for that, and we have a huge quality department, so we could review the data, review the ED, outcomes, etc., and kind of reassure ourselves that there was no miss at the time of the electronic visit. Some of us will just get sicker within 7 days for whatever reason. A cough that starts off and you think it's fairly benign may well be the harbinger of pneumonia. And I might well miss that even in the first, cut, whether it's in person or by telephone or what have you. So there's that. And this was kind of the breakdown where follow-up rates for the different avenues of care that we provided. So
Can you contrast them? What's an e-visit versus a secure message? They sound awfully similar, but
yeah,
not quite.
yeah. So secure message is the simple emailing system that we've had for, and we've had, Sutter has had it and Pam has had it. It's like, I'm just writing an email, My birthday's coming up, I'd like to get my cholesterol done. That's an email, and that's a secure message, secure email. And e-visit is this really formatted structure where you can go down this path if you've got no chest pain, no shortness of breath, et cetera, but also you're going down this path for a upper respiratory infection or a urinary tract infection if you have these symptoms. And that's how you complete the e-visit.
The patient doesn't like tell a story that they have. It's more like, and I've used it, the things I know about it.
Yeah.
Like an expert system wizard. They're clicking through. Do you have one of these symptoms? Yes. Okay. How long have you had it for? Click. And they're clicking through. That's kind of
Exactly.
the following a decision
Exactly.
branching pathway.
It's like an algorithm that we build, a clinical decision support tool. You get bumped out now if you've got a urinary tract infection, but you also have fever, because that's no longer simple UTI for anybody with this clinical field. We had a great study in New England Journal like too many years back that proved to us that we could treat these patients without doing further, testing or evaluation or examination or what have you, if they have XYZ, but none of these other factors that suggest a systemic infection, that the infection hasn't gone beyond the bladder and the urinary tract. And so using that evidence-based medicine, building these, and now you've got fever, you've got chills, you've got nausea, you cannot come down this pathway. And so, yes, it's not for everybody, but it is for the lower risk patients. For symptoms that we know we could manage really well. Symptoms requiring in-person exam, I'm feeling dizzy, no. Because I could be dizzy for a number of reasons. Could be something simple in the inner ear vestibular, could be something going on in the brain. It could be just that I'm low on my blood pressure's low. I could be really, really sick. I could be septic. So some of those, you're just bumping that off. It's conservative medicine. It just has to be conservative. Having said that, there's enough volume out there that we can, really take care of these patients. Technical challenges, they're one area we see, we saw, and not only for this study, but for some other studies that we've done, is that the one characteristic where we find that digital stuff is, it's not age, that's a big reason why they're not connecting with us on this digital platform. It's the areas with low socioeconomic status where the internet connectivity is overall low in that geographic area. Lack of familiarity with the digital interface, that's for sure. It's like, where is that? What is that? Because truly upfront, we did not do any amount of patient education or marketing, etc. We just go the way we did. One big limitation I do feel is that when we provide not only digital care in the form of electronic visits, but any kind of virtual care, but we miss the opportunity for good, solid preventive routine, which are patients. So it's not for the frequent flyer, but there are enough patients that the only time they're gonna call is when they had the sore throat. The only time they're gonna call is when, there was some back pain. You took care of it digitally, so what? But, that was that golden opportunity that when they were sick, their threshold to come in is low. They could have come in if they didn't have this quick, easy pass. And now we didn't grab that opportunity. We missed that opportunity to check their blood pressure, talk to them about, anything else we needed to, your colon cancer screening, your prostate screening, et cetera, that. So, life's a balancing act, and especially at the end of the day, healthcare is a business. And, it's like dollars and cents, and where do we do this and where do we spend that, and limited resources. But it's something to keep in mind, or whether we create filters and stuff like AI and so forth will help build more robust systems than what we did in 2018.
You can finish your sentence first.
All right, sure. But here's the filter we could put in. Somebody who has not accessed care within the last 3 years, nudge them. Even if you don't block them, you might nudge them to say, at that opportunity, Mr. Smith, you haven't, come in to see your physician. and, he's 25, then that's okay. But if he's 65 and he hasn't, then phenomenal. So there's so much that we can do with this platform, knowing a few other parameters, et cetera, and knowing that this is safe to take care.
I was wondering if you could measure that, like how many of the folks who got an e-visit got an annual exam as well?
Totally, we can do that. We could have done that even then, and now more so, we definitely can. So there's so many ways to slice and dice this. And some of it we did do, looking at this, but you're absolutely right.
And also, I'm wondering about like, so this digital divide problem is huge. If, say, for example, you have poor or no internet connectivity, did people then move towards like telephone visits, or did they actually come in person? Were you able to?
There's a very good and high adoption. So we looked across the board, and we have some of that data, but not like off the top of my head. But the adoption for telephone visits is so high across all, age groups. It's amazing. And if you think about it, we created these telephone appointment visits. These are scheduled visits, etc. For us, we did a huge, big push in 2008. But that's the oldest way of doing things, right? The results come in, and probably even 40, 50 years back, Dr. Smith called up the patient to say, I see your chest x-ray and it looks good. That was telephone care, or this looks bad and I want you to start XYZ. So for our patients to adopt that, it was really, really easy. It wasn't hard. The adoption of video visits, on the other hand, in which they had to go to a different platform, our own platforms had to get much better. The initial connectivity for video visits, and I'm talking about 2016, 2018 kind of a period, was about 50%. And there was a big push from the folks who were building the video visits. Hey, open it up for every symptom, everything out there. But my take on it was, well, we've got one satisfied patient and one extremely frustrated patient if our connectivity is 50%. And so we started off with offering it for things where an image is worth 1,000 words or whatever, like for skin problems and injuries and things like that. So it was very targeted. And then once the video visits took on, opened it up for everything else. All of you know, the adoption wasn't great pre-pandemic. Pandemic, like we didn't have to ask anybody. Everybody was asking us, can we have a video visit? And we had an amazing platform. We'd already built it. We'd already built it with all the bells and whistles and everything else. And we could just run with that. So that was kind of fortuitous that we had. All right, just a few takeaways. It is successful. Now, there is some of our medicine that is simple, straightforward, high volume, crazy high volume, that totally overwhelms the offices, telephone care, everything else out there, the nursing and so forth, that can be channeled through the digital platform. And our patients want that. They're feeling sick, they don't really want, kind of know what that is, but they still need to connect to kind of make sure. Having said that, you would think that if we did this, the volume for our telephone care would have dropped. Did not do so. It's funny, you build it and they will come. And when they're not feeling well, no, don't give me some digital, what have you? I need to connect. That warm voice of being seen. That is very real. That doesn't go away, however good your tools are. And that's okay, because there's the patient's wants, needs, we need to accommodate, that's what we're here. Take care of this whole patient, even if it's, it's just a nasty sore throat that's bothering them and so forth. Clearly provides increased flexibility. Lots of learnings, as you said, can we slice and dice this, the patient who hasn't come in, patients who's completely new to a system, the patient who's behind on their blood test, is diabetic, hasn't done a hemoglobin A1C, that blood test, for, 11 months, because there's an alert. The other way also is as we learn more and know more and again, amazing technology supporting us, not every diabetic is the same. The only way we lumped it right now was diet. You have diabetes. The patient who has diabetes is really well cared for, and his hemoglobin A1C is like 6.6, is really very different from the amazingly uncontrolled diabetic who's very high risk for every infection, everything else out there. And so, yes, and we parse this out, can our systems build it better so that we let the patient who is reasonably controlled come through, use all of these systems. Why are we blocking them? And really do block that high-risk patient. You're diabetic, but you're high risk because you're so poorly controlled, you never, your compliance with medications. We're an integrated system. We've got all the data, and now, we're talking to each other. So when I'm seeing my patient, when I was seeing my patient in Kaiser, I knew that they'd been to PAMP and Stanford and so forth, where all these systems are talking. And I can look at their art and see, but then we can build filters to match that. A reduced burden on healthcare system, that's a given. Like, what can we do? What can we build? Which becomes like a no-brainer, or takes a physician 2 to 3 minutes instead of that 20 minutes. And the resources, the physical space, and you need the receptionist, you need the medical assistant, everybody else, long-term impact on the healthcare costs, utilization, and so forth. And consideration for implementation, some clear guidelines. You have to have everybody on board that's on this, as well as what's appropriate, what's not appropriate. So again, the fact that I have this group where we call them the Scripts and Protocols Oversight Committee, worked with them. There was a huge trust built with the number of folks that we had that were really strong clinicians. You just had to be. And then presenting data in digestible, transparent fashion, and slicing it, dicing it correctly. Say, here's a trend. This is what we did. Oh my gosh, we increased the number of appointments for the simple thing, or we did the right thing, or we sent the patient to the emergency room, we did the right thing, or not. So all of that is this checks and balance to make sure that does this need iterations and things like that. Quality of care, patient satisfaction, is patient happy, or they think they're getting the runaround. It's like, this is like, I paid so much, and why am I just having to deal with this question? And nobody wants that, right? But some do. And so that's basically where we are. I think it's an amazing tool, it's proven to be. So future for e-visits. I just checked that, and there's this HIN survey, which checked in 2022 that 75% of individuals are offered online access. So they have a patient portal, whatever they're doing. Adoption for physicians is of course much, much higher, but patients accessing seem to be 75%, which was like a huge increase, was like a 25% increase over 2 years, like 2 years earlier was much lower. COVID clearly changed the game for us. And so the challenges for us would be addressing the rising costs, the projected shortage, everybody's heard about that. So how do we take away some of this low-hanging fruit in a clinically safe fashion? That's where we are. And with that, I'm open to questions or comments. And
Thank you, Dr. Rheena.
Or otherwise, I have a couple.
there's a hand, right?
Thank you so much. It's amazing talk, and it's a very interesting systems. My question is related to, you mentioned you use integration between the EHRs, and so I would like to see you receive some symptoms from the symptom information from the patients, And so I would like to see all the information are recorded in the EHRs, diagnosis codes, or for example, all these information only mentioned in the clinical use. I don't know how you use this integration. The data comes from, for example, do you provide some patient profile based on the EHR data that we have for the given patients? You, for example, provide this view for physicians when want to make a decision, or any information you get from the patients, for example, the symptoms and something like are recorded in the EHR or no? My second question is related in terms of cost. What kind of benefits this system provide for patients in terms of reducing the cost, and in terms of the healthcare provider, what kind of benefits?
Yeah, one answer.
Good points, excellent points. It's all in the electronic medical record. So patient goes to their patient portal and everything's right there. And then they might say, they have the option. They could bypass the electronic visits and just book themselves an appointment just because they've got, say, diarrhea. But on the other hand, they will be offered the option. You could consider an electronic visit. Everything is sitting in their electronic medical records. Now, the pool of physicians that's working on this has maybe like 25 of these electronic visits sitting there, but they're all attached to the electronic medical record. So when they pull up this encounter, e-visit encounter, just like it's a telephone encounter or any other encounter, then there's we attach this whole smart set to this encounter. So right there, that's why their processing time is only 2 to 3 minutes. Right there, just because this patient came down the pink eye track and uploads their picture that looks like subconjunctival, tiny little break in the blood vessel, the subconjunctival hemorrhage. There's a diagnosis attached to that, where the smart set has a diagnosis, a smart phrase. It's all pre-populated in a sense, because this pops up in attached to the e-visit encounter, which says, Mr. Smith, sorry, thanks for using this e-visit. It looks like I've reviewed your medical history. It looks like you have XYZ. They can edit it. They need to edit it for whatever reason, because I've got the med legal responsibility. I'm the clinician. That's why physicians have. But the likelihood that they need to edit it is really, really low, because the patients come down this path. We've already bumped them out. If they have had a huge change of vision, they're not coming down this pathway. That's the expertise we used in making sure these are safe and really kind of slick algorithms. And so it's sitting in there. And then as far as the cost goes, there's no charge to the e-visit for the patient, just because Kaiser is
It's Kaiser.
Kaiser is what have you, like prepaid or what something like that. There are co-pays for a number of things, and again, in between, CMS got involved, even looking at the co-pays for telephone visits, video visits, because COVID happened and so forth. So I'm not an expert on what those other visits cost these days, and there are co-pays even for Kaiser patients. But e-visits were no, because I don't think CMS recognized it as a visit. And so when they don't do that, there's no dollar amount attached to these things.
Okay, you mean to have free?
Yeah, they're free.
Okay.
Totally.
It's free, but okay. Same way you said, Professor Julianne Milstein's asking a question really on the same topic. I know it's a different system, but Julie, why don't you take that conversation to the next level?
Yeah, so I mean, CMS does actually have billing codes for e-visits. And I think the challenge with them has been differentiating a real e-visit from something that is less than a visit, that's just, a simple exchange over secure message. So I'm curious, I feel like you defined what an e-visit is and therefore what an e-visit isn't. And so do you see a way that that could be translated into regulation? Because right now the regulation to qualify for an e-visit is just so complicated that no one's billing for them. because it's like you have to say, did I spend this many minutes? Was it for a new acute issue? It's like, it's just too complicated to operationalize. So I'm curious, is there sort of like a simple way to really define an e-visit in a way that could allow for billing to really take off and then this model therefore to expand?
Excellent point, excellent question, and that is not an area where I'm the expert. You're absolutely right, a good point to bring up. E-visits can be defined in any which way. And so this, what I described was a physician interaction and a physician care model. We pivoted over time. The diarrhea e-visit that we built, I built that as a self-care model. There's so much in self-care one can do in diarrhea. We ran it by the chairs of chiefs of gastroenterology, the chairs of chiefs of infectious diseases. They were very comfortable with that. And we essentially built it as a self-care model without a physician interaction. So CMS would have a problem with that, right? Like you're calling that an e-visit. So under the umbrella of e-visits, there are very many models out there. And I guess that is what CMS grapples with as well. Come COVID, we went into shelter in place on a Monday in March 2020. And because we had this platform, by Friday, I'd helped build a COVID e-visit. And that was a completely different model. That with no physician interaction. We already knew we were drowning as far as the physician workforce was concerned. We had a really good sense that there was a pandemic coming. By that time, it was pretty darn obvious that even in January 2020, when these calls started coming in and our patients calling with, been to China, heard about this, et cetera, brainstormed and created an electronic letter with tons of information. So that was email communication. Another person might call that's kind of an e-visit. We did not call it an e-visit, was just called it an electronic letter, knowing that 99% of our physicians are going to say the very same thing. It's hard for everybody to stay on top of their, information, et cetera. So let's centralize this as much as possible. Then we can edit this letter as need be, but that was electronic communication. And so under this umbrella, you're right. There's a lot of things people call. Some of them are non-physician managed e-visits. That's a very, very common model. And some of our peers, in different parts of the country use that model, but frankly, we've looked at that. We still do believe the ones that are done by the physicians are safe. Our patients feel good about that, and it just seems the right thing to do.
I'm gonna squeeze in a couple more lightning round questions here. Many of us have generalized AI advice system. That seems very cool and very great for a science project, but maybe 80% of people's questions are URIs anyway. And you don't need a fancy AI to do it. A simple decision support thing can handle that. Is that true or untrue? What do you think?
I do think AI is gonna help us. It may well tease out this patient with COPD or what have you. I do think, whatever we can do, learning the system, etc. And can use technology, why not? We will only get back, we were talking about the diabetic who's with a hemoglobin A1C of 6.6 versus 9.6. Maybe the AI should help us weed out who's the higher risk, who's the lower risk, let the lower risk go through. So I do think there are very simple models we could build with this, just to get it beyond the simple algorithm, to make it more sophisticated.
Here's a weird meta question that motivates a lot of this. If people hear the motivating problem axis and all this kind of issues, why don't we just hire and train more doctors? If there's that many patients, we should just hire and train more doctors. I know that's not really up to us, but why isn't that the answer at a system level?
May well be a good question, a good this thing, but I think this is way above our pay grade and everything else, et cetera. There should be way more medical schools, maybe more, but.
Fair enough.
There
is some policy things, but also you would never be able to train enough people to meet an unlimited demand is part of it.
When there's a patient want as well. Let them, something here on the phone I can do in 2 hours, I get the answer, I get a prescription, I can go pick it up, my physician, my PCP doesn't even know about it. I've been taken care of.
Mhm.
In 3 hours, I have the prescription, I've taken my first pill. Why not? So I do think, but even so, I do agree with you. That we should have more physicians.
A lot more we can discuss, but I think provokes a lot of interesting discussion, but it's not just discussion, like, this is an actual thing, it was actually built and people actually use it and made impact, so fantastic to hear about that.
We, for COVID, then as we built, we morphed it into many, models. And one of the things I was working on to publish was, we had millions of visits done for COVID, millions. And if you think about it, what if that was in a pipeline for the physician to answer or for the patient to keep waiting? It's like,
Yeah.
what am I supposed to do? Am I supposed to go out, not go out, get this test done, etc.? Where's my Paxlovid? You can have a COVID visit at the Paxlovid, and your physician doesn't know about it, and you've got your treatment started. Why not?
Oh, sorry, I gotta hear that last one. Who signed that prescription then?
So the physician who's
Your primary care doc doesn't know, but there's some physician who just answered e-visits all day.
dog. And now, Paxlovid treatment can be managed by pharmacists as well. Pharmacists can sign off on
Following a
Paxlovid.
protocol, right?
But, yeah, Walgreens pharmacists could have given us Paxlovid too.
Yeah.
They opened up Paxlovid to pharmacists. But for everything else, yes, there's a physician side.
Great, we're already past time. There's too much great things to discuss. Let's continue the discussion another time. Thank you again so much, Dr. Bhargava.
It was such a pleasure. Thank you.
Thanks, everybody. Be back next week.